Hello, my name is Dr. Susan O'Brien, and I'm the Ashbel Smith Professor in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. I'm often asked, what are the recommendations for monitoring and mutation analysis in CML? The initial monitoring is based on cytogenetics or PCR, but it's very important that the PCR that you're using is standardized to the international scale. So that's something you need to check with your laboratory to see if they do that. Otherwise, the early monitoring is recommended to be the gold standard, which is cytogenetics. Obviously, both physicians and patients tend to prefer PCR because it can be done on the peripheral blood. Nobody loves bone marrows, but nevertheless, it's important if you don't have access to a standardized PCR that you do perform a marrow to look for cytogenetic response. Once a complete cytogenetic response is obtained, then the monitoring is strictly by PCR. We recommend it about every 3 months. Keep in mind that although we like to see major molecular responses, we don't change therapy based on lack of molecular response. So you might say, well, if I'm monitoring this, why am I monitoring it if I don't have a major molecular response and I'm not going to change therapy? Because what you're really looking at is the pattern. So for example, if you have a patient with a molecular response and at the next evaluation point that PCR has gone up by a log, that may be telling you that this patient is relapsing. And what that's telling you to do is not change therapy, but to do a bone marrow and look for a possible cytogenetic relapse. Because keep in mind, we want to detect those before we have frank hematologic relapse, because if we detect loss of cytogenetic response and then switch therapies, the patients do much better than if we wait till they have a frank hematologic relapse. As far as mutation analysis, in patients that are having a nice response to therapy, there is no point in doing mutation analysis because you will not find an abnormality in a responder. The time that you want to do a mutation analysis is when you have a patient failing by a number of criteria that are clearly outlined in the guidelines, and then because you have a failing patient, particularly in patients who initially responded, you want to see if there's a mutation, because that can help you in your choice for second TKI, depending on what that mutation analysis has shown. So in a nutshell, if the patient's responding and doing well, there's no need to ever do mutation analysis, but if your patient fails treatment based on a number of different time points, that time point is when you should be looking to see if there's a mutation.